Thank you so much, ma'am. So good afternoon, everyone. Today I will be telling about role of LH in ovarian stimulation. So let's start with something very basic. Each one of you are very much aware of the facts that. As we know that a lot goes on inside the follicle for oocyte maturation. There are involvement of number of factors, number of hormones, especially FSH and LH. It is an orderly fashion is key for development and for maturation of the follicle, for which is very required for a healthy pregnancy. Now, LH receptor, we all know they are present on the theca cells, and FSH receptor, they are present on the granulosa cells. But ovarian steroidogenesis is very much LH dependent to a significant degree. So this is the two granulotrophin cell theory. You all know that first cell is the theca cell, and this is the granulosa cell. So basically what happens, this LH first act on the LH receptors, and then the series of events will start in the theca cells. Basically, it starts with the cholesterol main compound, and then the series of events leading to the 17-hydroxyprogesterone. Then this is the A4 is the androstenedione. This will be transferred in the granulosa cell, and in the granulosa cell, FSH will act, and with the help of aromatase enzyme, it will be converted into estrone, and finally the estradiol, which is very much required for the follicular growth. So this we already know. Now, there is one concept, that is the LH window concept. In the follicular phase, there is a threshold and a ceiling for ideal LH concentration. How should be the ideal? How much is the ideal concentration for LH? Why it is important? Because we all know that for optimal follicular growth, we require the levels of LH should be above a certain threshold. So values can differ from here to here in some studies. This is from Gardner. So basically, LH the values are between more than 1.2 and to 5 international units, to less than 5 international units. Because what they have seen that if this threshold has not been reached, then the follicular growth is impaired. There is inadequate androgen secretion, and there is oocyte maturation is also not complete without that. Then, but if this threshold is above the normal, like if the LH levels are above this normal, then what will happen? There will be suppression of granulosa cell proliferation, follicular atresia, and premature luteinization can happen. So this is the same slide that within the therapeutic window we have to keep this LH, that is 1.2 to 5 international units. But this LH, during the time of LH surge, we all know that during the time of the ovulation, so basically this LH will rise. It is more than 20, it has been observed that it initiates the continuation and completion of first meiotic division. We all know first meiotic division, it starts with the rise of this LH, but obviously the second meiotic division, it will complete only when the sperm entry will be there. So to initiate this meiosis in the oocyte, this LH rise is very much important. And after 10 to 12 hours, as you can see in this figure, after 10 to 12 hours of this LH surge, LH peak, the ovulation will occur, that the follicle will rupture. So luteinization, now this LH surge, what will it do? First, it will do the completion of meiosis. The oocyte is arrested, but when the LH surge will be there, the meiosis will be initiated. Then luteinization of granulosa cell and production of progesterone, and release of oocyte by progesterone infusing mid-cycle rise in FSH and freeing the oocyte from the follicular attachment. So basically, for the ovulation, yes, LH surge is very much required. Now, LH supplementation in ART, we will be discussing in detail in our next lecture. But yes, we know that LH plays a very vital role in quality of oocyte in poor responder and women in the older age group. Even though the level of LH is within the normal range, but it is inactive, not inactive, but yes, the receptors are very few as the advanced ages there. So, using HMG or recombinant LH, this will be done in detail in the next lecture. Now, coming to the poor responder, if you see there is a one concept, that is a FORD and FOID. You must be aware of these terms. Just to brush up, that FORD is basically the follicular output rate, which evaluates the proportion of the follicles that are responsive to the FSH. Basically, the number of pre-ovulatory follicles divided by the antral follicles. The number of the follicles which we got after we give the injection to the patient divided by the antral follicle. And the second is FOID, that is a follicular oocyte index. It is basically the number of follicles which we have retrieved at the time of ovulation divided by the antral follicular count. If you see in this figure, so normal FOID is more than 50%. It means that, let's see, assume that this is the 20 oocytes, 20 AFC I am seeing of one patient. So minimum eggs which I should be able to retrieve is at least 10 10 or more than 10. But in the second case, the same. This is also normal. Like if the number is less, number is 10, then it's okay if I am able to get a 5 oocyte. But if it is what is low foil, that is less than equal to 50%, then even I am able to see the 20 eggs, but I am not able to retrieve the proportionate eggs. So this is fourth, that the follicles are responsive and follicles are there hyper-responsive basically in these patients. So while foil is, according to you, fold and foil, it is a foil which is more important because the ratio between the number of oocyte collected at the time of ovum pickup of the antral follicles, it is basically a novel parameter. Initially we are using this AMH, AFC, they are also very good predictors, but at the time of ovulation, if I am at the time of retrieval, if I am not able to get more than 50% of foil, then it means as in somewhere I have an idea that obviously the response is impaired. So this is, I think, the same slide which I have explained. Now, what can be the possible reason for low follicular to oocyte indices? So first of all, the starting dose of gonadotropin, the first box is that the starting box of dose of gonadotropin is low. This is more in the cases where we are not able to see the other factors, like the patient is very much obese, patient has a previous poor responder, patient is advanced maternal age, which is a higher dose is required, but still we are starting with a lower dose. So this can one of the factors. Then we all are aware of the genetic polymorphism, that is FSH receptor and LH molecule polymorphism, in which even if we are giving, like the patient is absolutely fine, she is a young patient, we are giving the FSH, we are giving LH, but she is not responsive. So this can also one of the reasons. Then asynchronous follicular development, it is very much common, which follicles are very small and some are already 14 to 15 mm. We see very much we are seeing this type of things also in the poor responders. And then the technical issues obviously involving with triggering of for the final oocyte maturation or the pickup. So basically any technical issues can also be there. So yes, foil could be useful to predict the likelihood of success in ART, both concerning the chances of achieving at least one euploid blastocyst. Because if the number of oocytes are more, then the obviously chances of achieving one blastocyst, which is we require, is more. So hypo-respondent normo-gonadotrophic women with a normal ovarian reserve who required elevated doses more than 2500 to achieve an adequate number of oocytes. Basically, hyper-responders are any patient who are not able, we are not able to either see the proper growth of the follicle or the E2 levels, the estradiol levels are not adequate. So this is the same that we are giving the adequate FSH stimulation, but still they are unexpected poor responder or suboptimal responder. So this one I was talking about, that LH polymorphism. Okay. So LH, there is a variant of the LH molecule which is less efficient, or there is problem with the FSH receptor, and higher doses of FSH are required and carriers of FSH receptor and LH polymorphism. So is there any way that we can identify, like obviously we know that if the AMH is less, if AFC count is less, patient is of advanced age, we know, we have some idea that yes, this patient is a poor responder. But if the patient is, everything is fine, then what other parameters we can see? We are daily, obviously before starting the stimulation, we are doing this FSH, LH, E2 and P4. So if you see the FSH, this is I don't have marker pointer. First is unexpected poor responder. If you see the FSH, it is slightly more, 6.7, around 7 is there as compared to the normal responder. So FSH is also one of the criteria which you can see if just to which dose you want to start. Now, proceeding concept, that is a patient-oriented strategies in canvassing the individualized oocyte number. It is a new, more detailed stratification of low responders. It basically have the 4 subgroups, and it involves age, expected aneuploidy rate, ovarian biomarkers, and ovarian response. So, Procedure has divided the groups into the poor responder groups into 4 categories. First 2 are unexpected poor response. Why unexpected? In Procedure group 1, they are young patients, that is less than 35 years. And in Procedure 2, they are more than 35 years. But the AFC count, the parameters, the AFC is more than 5 or AMH is more than 1.2 in both the groups. So they are unexpected poor responder. That we are not expecting such a poor response of these patients. Then proceeding group 3 is less than 35 and proceeding group 4 is more than 35. But in this the expected to respond, why is expected? Because the AMH is already low, that is 1.2 nanogram per ml, and AFC is also less than 5. Now, what can be the, this also will be dealt in detail, but yes, just to give you an idea that proceeding group 1, because we are not expecting that these patients will respond poorly, so what we can do? We have to reassess the ovarian reserve testing, whether the ovarian reserves is okay, previous stimulation, how is it? Checking for genetic polymorphism, it is only in the books, we never check because it is very, very expensive and it is not available in all labs. So yes, this is not which we are doing daily. Changing the stimulation and protocol strategy. Stimulation, we are basically doing the NAG protocol in all 99%. Then yes, FSH dose we can start. The starting dose can be increased, or we can use recombinant or HMG from the beginning of stimulation with a dose of 75 to 150 in these patients. So similarly in 1B also, that's same. So 1B is basically, I have not told you that group 1 is further divided. Group 1 and group 2 are further divided into group 1A and 1B. Group 1A is if less than 4 oocytes are retrieved, and if 4 to 9 oocytes are retrieved, it is group 1B. Now group 2, same things, because they are a little bit older patient, more than 35 years of age. So what we can do, we can add recombinant LH from the beginning of stimulation, that is 150 international units, or we can also do PGS, that is the aneuploidy screening in these patients. Now proceeding group 3 and 4, now we all know that this is a patient with less than 35 or more than 35 years with poor ovarian response. So group 3 treatment options, we can use the higher dose, 300 or 400 or maximum of the 450 we can also use. But generally 300 is suffice. Then dual stimulation, yes, it is also, because we all know that there are the multiple waves, follicular waves in one stimulation cycle. So yes, the dual stimulation can also be given. Then the androgen therapy, we can use growth hormone, DHEA, like we are using testosterone. But still, which one is very much ideal for these patients are still a debate. Then oocyte embryo accumulation and FT, that is we can do the pooling of the embryos. That is the patient can undergo dual stim in the same cycle, or she can go for another cycle, multiple cycle, and we can do the pooling of the embryos. Then group 4 is the okay, group 4 basically you can try anything, and these dose can be increased, dose stimulation can be done, and in these cases especially PGS can also be one of the things, because in group 4 the age is also more than 35 years. Okay, so and the studies have also been shown that the intraovarian PRP that we are using with the laparoscopically we are putting, or we are putting the transvaginal needle. So these can also be done, but they are still under the research only, I think. And then the stem cell therapy can also be given, but in these patients. But yes, we have to counsel the patient. It is very, very important that the response, we are expecting the poor response, we are expecting the less number of eggs and the less number of embryos. And even if the embryos are okay, then still we don't know the quality, because the age factor can be there. Then she can also be counseled for the oocyte donation. So this is the same. I've already explained that growth hormone, DHEA, testosterone, coenzyme, CoQ10. Yes, you can give, but yes, there is insufficient data. Which one is better? Then, if you can see that group 4, I think I've mentioned that adding LH 75 to 150 international unit, or double stimulation in the one menstrual cycle, that is a dual stim, you can do. It improves the recruitment and development of follicles. It improves the recruitability, and multiple follicular waves can be, because they can be there. So when is the correct time? So basically studies have seen, these are also multiple studies, it is also based on the experience of the clinician, but still I have put some slides that the studies have seen if you are putting the LH from the complete follicular phase, and complete follicular phase there is a clear benefit is there, and if we are putting the LH from the late follicular phase, then the clear benefit is not there. But still it is also, patient selection is very important. Like if the patient is advanced maternal age, poor, already a poor embryos in the previous cycle, then obviously we have to add LH from the follicular phase only. So LH supplementation is mandatory in hypo, yes, we know hypo response is different from POR. This is crucial for right interpretation of RCT results. And the concept of low prognosis should be developed considering new categorization, which we have already explained. And So basically, yes, the practical endpoint should be considered in clinical real life. That is, we have to, we just want one euploid blastocyst who can just implant. So thank you so much.